Everybody, and welcome to Psychiatry Grand Rounds. My name is Tony Rothschild. I'm the chair of the Grand Rounds Committee. Just a couple of brief announcements. In order to receive credit for attending Grand Rounds, please fill out the Survey Monkey that came with the Grand Rounds announcement from Karen Lamberg this past Monday. Grand Rounds is going to continue to be on Zoom and not in person. I imagine through the end of this academic year through June. If you have questions for today's speaker, please put them in the chat function, and then we can ask the speaker at the end of his talk. Next week's Grand Rounds, unfortunately, the speaker had to cancel, but we are trying to arrange a possible presentation on the new medical school curriculum called VISTA. So stay tuned. Check your inbox for messages and we'll send out an announcement. Grand Rounds the following week on March 3rd, 2022 will be given by Dr. Marcia Ellison. Dr. Ellison's talk will be practices and policies that prepare youth and young adults with mental health conditions for employment and careers. It's my pleasure to introduce Dr. Hussam Jeffy Balloul, who's the medical director of the Addiction Consultation Service, who will introduce today's speaker. JB.
Hello, everyone. Thank you for joining us for today's Grand Round. It is my absolute pleasure to introduce Dr. Girma. He's our addiction psychiatry chief resident this year. He finished his bachelor's degree of health sciences from Boston University and then went on to Philadelphia College of Osteopathic Medicine to do his medical school. Then he joined the Geisinger Medical Center in Danville, Pennsylvania to do 3 years of psychiatry residency before he joined us as a PGY4 this year. And as chief resident of addiction psychiatry, I have the pleasure of working with him on the addiction consultation services. He is such an insightful and amazing clinician, and I'm looking forward to his presentation today, and I'm looking forward to see him advance in his career as an addictionologist. So take it away, Aedome.
Thank you for that wonderful introduction, Dr. Jeffy Balloul. As Dr. Balloul mentioned, my name is Dr. Girma, and I'm here to talk to you all about the management of substance use disorder in the outpatient setting. I do not have any actual or potential conflicts of interest in relation to this presentation, but I would also like to take this time to thank all those who have contributed to my education in the world of addiction, including you, Dr. Jeffy Balloul, Dr. Gonzalez, our recovery coaches, Amy Nicholas and Brian Trillia, and our social worker, John Manfredo. In addition, I would like to thank Drs. Padilla, Benjamin, and Dr. DeGroche and Vicky White for providing me with this opportunity to be here with you all today. I will be discussing off-label uses of the following medications: gabapentin, topiramate, baclofen, and mirtazapine. The objectives for today's talk is to describe the neurobiological model of addiction, to describe the risk factors associated with the development of a substance use disorder, to describe how to conduct a general assessment for a substance use disorder, and to explain the management of benzodiazepine, stimulant, alcohol use, and opioid use disorders. It's important to have a fundamental understanding of the neurobiology of reward and addiction and how this propagates the cycle of addiction. Volkow et al. Published an article in the New England Journal of Medicine in 2016 that broke down these stages in several phases and gave a nice summary of how these different things are interrelated and how they propagate the cycle. When somebody uses an addictive drug, it activates our mind's reward system through sharp increases in dopamine release. At the receptor level, these increases elicit reward signals that trigger learning and conditioning. Repeated exposures to these substances lead to the association with the cues that preceded it. So repeated exposures to these particular substances and the environmental stimuli cause dopamine cells to fire in response to the environmental cue alone. Even in the absence of the drug, these dopamine cells fire and increase the rate of dopamine. This triggers cravings, which in turn triggers drug-seeking behavior and ultimately use and abuse. But with chronic use, we get changes that occur in the prefrontal cortical regions due to downregulation of dopamine signaling. This impacts decision-making and increases the likelihood of continued use, and it's harder to resist the urge to use. And through conditioning and the reward and motivation system become reoriented to focus on potent release of dopamine caused by the drug. With chronic consumption results smaller and smaller increases in the release of dopamine and dopamine levels in general. So users no longer get the same level of euphoria that they once experienced using this addictive drug. And withdrawal often results. And when that occurs, users become highly dysphoric and leads to a motivation to want to consume the drug in order to obtain a transient relief from the dysphoria itself. And this continues and propagates the cycle of addiction. It's also important to have an underlying understanding of the risk factors that are associated with developing a substance use disorder. Trauma, poverty, genetics, and underlying psychiatric disorders all play a role in increasing the risk for developing a substance use disorder. Alcohol use disorder, for example, has a 50 to 70% association with the development of an alcohol use disorder in offsprings themselves, if there is this family history of this disorder. I would like to focus in on the comorbid psychiatric disorder and how that increases the risk for developing a substance use disorder. Now, there's an article, a study that was done in 2007 by Compton et al. That looked at the association between psychiatric disorders and the lifetime prevalence of developing a substance use disorder. And they identified various psychiatric disorders that have increased associated risk of developing a substance use disorder. To name a few, bipolar I disorder had a higher association with the development of a substance use disorder, as well as panic disorder. Specifically, panic with agoraphobia had one of the highest rates of association with developing a substance use disorder. And in regards to personality disorders, antisocial personality disorder had one of the higher rates of association with the development of a substance use disorder. So I say that to essentially say this, that when we are evaluating somebody for a substance use disorder, it's important to keep in mind, do they have an underlying psychiatric disorder? At times when a patient presents to us and they're having symptoms of anxiety or symptoms of depression or psychosis, the question that we should be asking ourselves is this presentation solely due to the use and misuse of a substance or withdrawal from that particular substance, or is it due to an underlying psychiatric disorder? And are they using these substances in order to self-medicate? This is important to tease out because that can impact your method of treatment. So if there is this underlying psychiatric disorder, you're going to want to treat that. So when we are doing our assessments, we want to be considering obtaining a longitudinal history with specific attention to these psychiatric symptoms. And also we'd want to inquire about what these mood symptoms are during periods of sobriety. Obtain family history when possible and collateral when possible. It's important to not conduct these assessments when somebody is intoxicated. Obviously, if somebody's intoxicated and you're doing your assessment, it could really muddy the data or the information that you're obtaining. when we are doing an assessment for substance use disorder, we want to be asking about substance or substances that they have used or misused. When did they first use the substance? When was the last time that they used the substance? How frequently do they use the substance? How much of the substance do they use? And in what route do they use the substance? Do they ingest it? Do they use it intravenously? Do they smoke it? Do they snort it or intranasal use? And what are some withdrawal symptoms that present when they're not using this particular substance? Do they have cravings or a strong desire to use? And what are some legal consequences that resulted from their use? A DUI, imprisonment, had to attend a mandatory substance abuse program. And it's also important to understand how the use has impacted their health. Did they develop hepatitis C or HIV from intravenous use and sharing needles? And in what context do they continue to use? A compromised liver, or are they pregnant and they continue to consume alcohol? And what is their treatment history like? What facilities have they attended or programs? Or they've been part of a detox, have been hospitalized, attended an intensive outpatient program? And how effective were those modalities of treatment for them? And also, what medications have they been on in the past to help address their substance use disorder? And it's also important to obtain collateral. A lot of the patients that we come across may be on a controlled substance. And it's important to query the PDMP or the prescription drug monitoring program to see if they are getting this prescription from multiple providers, refilling at multiple pharmacies. Oftentimes, this may be a red flag of potential misuse. Now, we utilize the DSM-5 when making diagnoses of a substance use disorder. And per the DSM-5, a substance use disorder is a problematic pattern of use leading to clinically significant impairment and distress in 2 or more of the following within a 12-month period. And you can think of it in larger categories, such as loss of control, impairment, withdrawal intolerance. For loss of control, you want to be thinking of symptoms of cravings, using more than intended, excessive time using and recovering from use, failing to stop, cut back, or control use. In regards to impairment, not meeting obligations at work, resulting in interpersonal conflicts, not being able to engage socially or doing previous recreational activities that they once enjoyed, repeated use in physically dangerous situations, and using despite psychological and physical problems. And also we're looking at withdrawal intolerance. So increased quantity required to get the same subjective effect, and the presence of withdrawal symptoms when not using the substance. There are specific specifiers that identify the severity of this substance use disorder, and that's dependent on the number of symptoms that are present. So for a mild substance use disorder, you may have 2 to 3 symptoms, and for a more severe substance use disorder, you can have 6 or more symptoms. Now, this is a picture depicting the family history or genetics associated with alcohol use disorder by Kevin Gates. Thought it was an interesting picture. And it also highlights the direction we're moving into, and that's discussing alcohol use disorder. Now, alcohol use disorder is a problem worldwide, and it's a big problem. According to the World Health Organization, it's estimated that more than 283 million people worldwide have met a current or in the past 12 months have met criteria for alcohol use disorder. And each year, nearly 3 million deaths have been attributed to alcohol use, and 5% of which were specifically due to alcohol use disorder itself. Now, alcohol acts on various receptors. One of the main receptors it targets is the GABA receptor, and alcohol is a GABA agonist. And through activity on this particular receptor, it has its inhibitory effects. Now, when somebody presents to us with an alcohol use disorder and is requesting assistance with that disorder, one thing that we should be thinking about and be aware of is the presence of alcohol withdrawal syndrome and the associated risks with this particular syndrome. So now, alcohol withdrawal syndrome occurs because of this. Essentially, when somebody consumes alcohol on a regular basis and consumes alcohol chronically, this results in an upregulation in NMDA receptors and a downregulation in GABA receptors. NMDA being more of an excitatory receptor, GABA being more of an inhibitory receptor. Glutamate is a neurotransmitter that has excitatory-like activities when it stimulates the NMDA receptor. When alcohol consumption suddenly ceases in someone that chronically consumes alcohol, there becomes this imbalance between excitatory neurotransmitters and inhibitory neurotransmitters, where you end up getting this excessive excitatory neurotransmitter stimulation. And this is what accounts for the development of this alcohol withdrawal syndrome. Stimulation by norepinephrine, stimulation by glutamate, causing this excitatory type of response. So within 6 to 36 hours of someone's last consumption of alcohol, symptoms of anxiety, symptoms of diaphoresis, insomnia, and tremors can present. Between 12 to 48 hours, symptoms of alcohol hallucinosis could present. Largely, these symptoms are auditory hallucinations. But it's important to keep in mind that although they're having these hallucinations, oftentimes their cognition is intact. They're able to focus and concentrate, but they're noticing that they're having these hallucinations. Between 8 and 48 hours, you run the risk of alcohol withdrawal seizures. And between 48 and 96 hours, there is the risk of the development of alcohol withdrawal delirium or delirium tremens, which is life-threatening. So it's important to be aware of these potential risks when we're considering managing alcohol use disorder. One question should come into mind is do I treat this patient as an outpatient, or is this someone that needs to go and be managed as an inpatient prior to seeing them again in the outpatient setting to help continue to manage their alcohol use disorder? The American Society of Addiction Medicine came out with a practice guideline, which was published in January of 2020, identifying particular risk factors that should be considered when deciding to send somebody for management on the inpatient setting. And that is the history of delirium tremens. And delirium tremens essentially being a reduced ability to focus, sustain, and shift attention over an acute period of time. A history of alcohol withdrawal seizures. That'll be also another consideration for inpatient management. If they had numerous prior withdrawal episodes, if they have comorbid medical or surgical illness, age greater than 65, really a long duration and heavy alcohol use history. If they're having a seizure during this current withdrawal period, definitely someone you'd want to send inpatient. If they have autonomic hyperactivity on presentation, so if they're hypertensive, if they're tachycardic, tachypnic, maybe this is somebody that you want to send inpatient. If they have a physiological dependence on GABAergic agents or like benzodiazepines, barbiturates, if they're concurrently abusing opioids, all these things can increase the risk for respiratory depression. So it's somebody that you want to send inpatient. And if they have a CWA score greater than 10, CWA is a scale that we utilize to measure the severity of withdrawal. And a score greater than 10 indicates a moderate level of withdrawal. So this is somebody that you may consider sending to the inpatient setting for treatment or management. And also, if, what is their social supports like? Is there somebody that is at home that could oversee or watch over them? Are they able to come daily to your office in the outpatient setting to be monitored? If not, this may be somebody that you may consider sending inpatient for management. Earlier, I mentioned CWA, and we mentioned a CY score greater than 10 being moderate. Well, it's important to keep in mind, what does a mild withdrawal, what does that look like? A mild withdrawal is somebody with some mild to moderate anxiety. They may be sweating, they may have insomnia, but they're not tremulous. Once the tremors present, that's when we go towards more of a moderate level of withdrawal. And once hallucinations are present, that becomes more of a severe type of withdrawal, and it's generally have a score greater than 19 or equal to 19. And then once seizures are present or delirium tremens, and that's at that point, that would be considered more of a complicated withdrawal. I'm here to really focus on the outpatient maintenance management of alcohol use disorder in this particular talk. There are behavioral interventions that should be considered when we're managing folks with alcohol use disorder. This includes 12-step facilitation, CBT, relapse prevention, motivational interviewing, and contingency management. In regards to pharmacological interventions, naltrexone is one of the first-line medications for the management of alcohol use disorder. This medication is generally taken by mouth and is taken once a day. The way this medication works is that it blocks the mu opioid receptor. And the thought behind this medication is this: when somebody consumes alcohol, it leads to the endogenous release of opioids, which stimulate this mu opioid receptor and cause a downstream effect where you get this increase in release of dopamine, which causes euphoria and which causes some of the learned behaviors that we discussed earlier on in this presentation. It's felt that by blocking this opioid receptor, we can diminish the release of dopamine and inhibit this downstream reaction and decrease the pleasurable effects that are associated with alcohol use. And that's what the studies show, that with use of this medication, there is a greater reduction in relapse rates, and there's been fewer heavy drinking days for folks that are on this medication. One thing that we should keep in mind is that this medication is metabolized by the liver. So if somebody has severe hepatic impairment, then that's a population of patients that you may not want to use this medication on, okay? So it is important to obtain or review somebody's liver function tests. Generally, if it's 5 times the upper limit of normal, then that's when we would consider not utilizing this medication. And also, it's important to ask, is this patient on an opioid agonist or opioid medication? And if they are, we want to refrain from utilizing this medication. Again, this medication, it blocks the opioid receptor. So if you were to prescribe it, somebody's on an opioid, you would precipitate a withdrawal that could be really discomforting to the patient. And our goal here is to help the patient. It's generally dosed at 50 milligrams daily. Some providers will utilize a smaller daily dosing of 25 milligrams daily for the first few days in order to minimize the risk for nausea. Additional adverse side effects include headache, syncope, dizziness, vomiting, joint stiffness, pharyngitis, not commonly seen, but important to be aware of. In addition to this oral formulation, there is an injectable formulation of naltrexone, also known as Vivitrol. Now, this medication is given every 4 weeks. The injection sites are the gluteal muscles, and generally, we alternate gluteal muscles every month when an injection is given. It's a dose of 380 milligrams, and some unique adverse side effects associated with the injection is pain at the injection site, tenderness at the injection site, and potentials for nodules and rashes that can occur at that injection site. Again, this medication blocks the opioid receptor. So it's important for patients to inform providers that they're on this medication if they do require some sort of pain management. The blockade can be overcome with larger doses of opioids in emergencies, also with peripheral blocks and other alternative management that pain management specialists can come up with or utilize. ACAMPROSATE is another medication that is FDA approved for the management of alcohol use disorder. This medication helps maintain abstinence. It helps ameliorate symptoms associated with post-acute withdrawal from alcohol. The exact mechanism of action of this medication is not known, but the theory is that it may help decrease glutamate release, which is more excitatory in nature, and reduce activity at that glutamate receptor. The dosing has an interesting name to it. They call it the devil's dose, or a dose of 666 milligrams 3 times per day is what this medication is dosed at. So when we are administering this medication, we want to assess renal function. It's metabolized by the kidneys. So that's why one reason why we'd be monitoring renal function. In severe liver disease, kidney disease, we would not utilize this medication. So if GFR is less than 30 milliliters per minute, then this is a medication that we would not utilize. But if it's higher than that, but there's some mild to moderate renal impairment, then you may consider utilizing a lower dose. And that being 333 milligrams 3 times a day. So it is a drug of choice if somebody has some sort of liver impairment. And oftentimes folks with alcohol use disorder may have cirrhotic liver, so something to consider. Some side effects, there's GI upset such as diarrhea, nausea, itching, anxiety. There's mention of depression and suicidal ideation in less than 1% of patients. I've never came across that, but that is a risk factor that's listed, and cardiomyopathy. Another FDA medication that's approved is DISULFIRAM. Now, before we get to talking about this medication, it's important to discuss how alcohol is metabolized in the body. Alcohol, also known as ethanol, is broken down to acetaldehyde and then further metabolized to acetate and then broken down to H2O and CO2 and other harmless byproducts. In each step of the way, there are enzymes involved in breaking down alcohol from one metabolite to another, okay? So ethanol is broken down by alcohol dehydrogenase to acetaldehyde, and then acetaldehyde is broken down by aldehyde dehydrogenase to acetate. If for some reason there was a buildup of acetaldehyde in the human body, it could cause this toxic-like reaction that can lead to headaches, throbbing head and neck pain, nausea, vomiting, hypotension, palpitations, even could cause myocardial infarctions or heart attacks and heart failure. This particular medication, DISULFIRAM, inhibits aldehyde dehydrogenase and causes this accumulation of acetaldehyde. And this occurs if somebody was to consume alcohol. So this medication has more of a negative reinforcement that's associated with it. It's important to ensure that somebody has not consumed alcohol within the past 12 hours prior to starting this medication. If somebody is on this medication and they do consume alcohol, they could have this DISULFIRAM reaction, this toxic-like reaction that I mentioned a few moments ago, that can occur. It can last 30 to 60 minutes, or it could last for hours. It's really dependent on how much alcohol someone consumes. The dosing is generally 50 milligrams daily, given over a period of 1 to 2 weeks, and then a maintenance dose of 250 milligrams daily. There's really not much dose adjustment that's required for hepatic or renal impairment. There are some other associated side effects, including this garlic, metallic-like taste, optic neuritis, peripheral neuropathy, impotence, in some case reports of hepatic failure. One of the key points that I want you to take away is that this DISULFIRAM reaction does not only occur if somebody ingests alcohol. If they utilize any alcohol-containing products, be it a hand sanitizer, a perfume, food products, cough syrup, it could also cause this reaction. So it's important that patients are informed of this potential risk. Off-label medications for the management of alcohol use disorder include gabapentin, topiramate, and baclofen. Studies have shown that a dose of 1,800 milligrams daily, gabapentin can be effective in improving or decreasing the risk for post-acute withdrawal syndrome, which is dysphoria, anxiety, insomnia. It could help with abstinence, and it could decrease heavy drinking days. The exact mechanism of action for this medication is not known. Generally, when this medication is started, you start at a dose of 300 milligrams on the first day, then increase to 300 milligrams twice per day, then on day 3 to 300 milligrams 3 times per day, and then you titrate by a dose of 300 milligrams until you get to a dose of 600 milligrams 3 times per day, giving you the 1,800 milligram daily dosing. It's excreted in the urine. Some side effects that folks may complain of is GI upsets, so nausea, headaches, dizziness, fatigue. There's always the potential for abuse of this medication. And there's some associated weight gain or peripheral edema associated with the use of this medication. So pyramate is another medication that can be used off-label. The studies show that at a dose of 300 milligrams daily, that particular dose, it's effective in reducing the number of heavy drinking days. And it also helps with some of the post-acute withdrawal symptoms. This medication helps augment GABA neurotransmission and also antagonizes that glutamate receptor, again, that excitatory receptor. The way you dose this medication is a slow titration of this medication. So you would use a dose of 25 milligrams twice per day for the first week, then 50 milligrams twice per day for the second week, then 75 milligrams twice per day for the third week, and lastly 100 milligrams twice per day for the fourth week. That gets you to about 200 milligrams in a 24-hour period. And at that point, it's important to assess for side effects and how they're tolerating it, and if they're not having cravings, and it's at that point you decide whether or not you want to continue to titrate the dose. You want to slowly titrate the dose because this medication increases the risk for Stevens-Johnson syndrome. And a fast titration of this medication could increase the risk of having this life-threatening rash. And that's one reason why we slowly titrate the dose. There are various side effects. Most of you may know, it's commonly known Dopamax, Topamax. That's just hinting at the association between this medication and causing some cognitive dulling. There's dizziness that's associated with this medication. It is helpful for weight loss, kidney stones. It may cause kidney stones, metabolic acidosis. Glaucoma is one that's important to keep in mind. Before prescribing this medication, you want to tell your patients that there's this risk for glaucoma, and if they were to have any sort of acute change in the quality of their vision, they should stop utilizing this medication and inform you of these changes. It also causes pancytopenia. Last off-label medication is baclofen. There was a double-blinded RCT that was conducted in 2011 by Adorato et al. And it showed that baclofen at a dose of 10 to 20 milligrams given 3 times per day was effective in reducing the daily alcohol consumption. And the greater the dose, at 20 milligrams, it reduced that by 68%, and at 10 milligrams, it reduced that by 53%. Next up is benzodiazepine use disorder. The exact number is not known, but there's this lifetime prevalence of estimated to be roughly 1% of individuals having this benzodiazepine use disorder. Per the Department of Health and Human Services, there has been an increase in admissions to drug treatment centers for the treatment of benzodiazepine misuse as a primary substance that they're presenting with, between 0.5% in 2007 to 1% in 2017. It doesn't sound as alarming as other substances, but I've come across this pretty frequently in the inpatient and outpatient setting. Somebody is on a benzodiazepine, has been on it for years, it's not effective, they're misusing it, it's not clinically indicated, or it's not treating the underlying anxiety, And it's important, and I bring this up because it's important to have a basic understanding of how we help folks come off this particular medication. Before getting into that, I'd like to discuss how this medication works. When somebody utilizes a benzodiazepine, it binds to the GABA type A receptor found in the cortex and the limbic system, and it enhances GABA binding to that receptor. This enhancement of GABA binding causes the chloride ion channels to open so more frequently. Chloride ions are negatively charged. So when there is this influx of chloride ions into the cell, it causes a hyperpolarization of the cell, making it hard to generate an action potential. And it's in this way it causes its inhibitory effect. When somebody is intoxicated on a benzodiazepine, they appear as if they're intoxicated or as if they're drunk. Okay, they may present with slurred speech, poor coordination, unsteady gait, antegrade amnesia. In overdose, you may notice respiratory depression, coma, stupor, nystagmus. When they are withdrawing from a benzodiazepine, you may notice symptoms like insomnia and anxiety within 2 to 3 days. They may have symptoms of tremor, diaphoresis, palpitation between 2 to 14 days. And they may have more severe symptoms in that same timeline, such as seizures or psychosis. In the elderly, this particular medication can cause confusion. It's also been associated to increase the risk of falls leading to fractures. So it's important to consider this when we are prescribing or considering tapering off this medication in this population. There is associated death from overdose when it's combined with opioids. And there is this increased risk of death in a dose-dependent fashion for folks that have chronic obstructive pulmonary disease. So how do we manage somebody that's on a benzodiazepine? Then they have benzodiazepine use disorder. Well, first, we want to switch from a short-acting benzodiazepine, if they're on a short-acting, like let's say alprazolam, to something longer-acting. There are equivalent doses that are out there for the various benzodiazepines, and there's charts that you could refer to, and I'll show you one in a moment. Once we convert to this longer acting benzodiazepine, we want to taper over weeks to months. If somebody's on multiple daily dosing of a short acting, you want to add up all the daily dosing, identify a long acting agent that you're comfortable prescribing and obtain that equivalent dose, and then start dosing in that manner. We utilize the longer acting benzodiazepines because they tend to decrease the severity of withdrawal symptoms and help decrease the rebound anxiety that may occur. The rate in which we taper per sources like UpToDate is by 25% every 2 weeks. Okay, but this really dependent on how the patient tolerates the taper. So we want to work with the patient because that's how we'll likely be successful in getting them off the medication. So some patients may require a slower taper. And they are on the benzodiazepine for a particular reason. They may have had some sort of panic disorder or whatever the case is. So we want to assess the underlying mood disorder and treat that accordingly, be it with the use of an antidepressant. If they have insomnia, we want to treat that with the use of sleeping agents such as mirtazapine or trazodone. So this is the equivalence chart that I was referring to. So for example, somebody's on 0.5 milligrams of alprazolam, that's equivalent to 5 milligrams of diazepine. So you can refer to charts like this to help you with converting to a longer acting benzodiazepine. Next up is stimulant use disorder, specifically cocaine use disorder. In 2013, cocaine was the most common legal drug that resulted to visits in the emergency department. Roughly 4.8 million United States residents were estimated to have used cocaine in 2015, and 18.6% met criteria for cocaine use disorder. In 2015, roughly 615,000 users received treatment for cocaine use. So I'm telling you of these numbers just to highlight that it is a problem in our country, and it's important to understand how to manage cocaine use disorder. When somebody uses cocaine acutely, it increases monoamine neurotransmitters like norepinephrine, dopamine, and serotonin in the CNS, as well as the PNS. Now, increase in dopamine in the CNS is secondary, or the central nervous system is secondary to blockade of dopamine reuptake transporters, and also inhibition of reuptake of dopamine at the synapses. With chronic use, you're getting downregulation of dopamine receptors. And it's important to keep in mind how people use cocaine. There's various routes. They could ingest it. It could be intranasally or snorted. It could be used intravenously. It could be smoked via respiratory tract. And the onset of action is really dependent on the route that's used, and really it's dependent on the route that's used. So if somebody is smoking or they're injecting, activity that could be within seconds. They could get the effects of the medication within the drug within seconds, and the activity can last 15 to 30 minutes. If it's snorted, if it's ingested, the onset of action could be 20 to 30 minutes. It may occur a little bit earlier than that, but generally up to 20 to 30 minutes, and the effect can last 1 to 3 hours. The peak activity is 20 to 30 minutes. It's eliminated in the urine. So when we are obtaining urine toxicology to assess for substance abuse, we're looking for the inactive metabolite benzoyl. And this becomes positive for up to 3 days in somebody that's using cocaine episodically. But with more chronic users, it could be positive for up to 14 days after use. So how do we treat underlying cocaine use disorder? That's a good question. We want to utilize behavioral interventions in conjunction with potential medications. So these behavioral interventions include 12-step programs, which initially or essentially promote abstinence. Therapeutic interventions like CBT for relapse prevention, in order to identify factors that promote the cycle of addiction, design alternative strategies, and prevent and learn and prevent relapse. Utilizing motivational interviewing to enhance the motivation to change, and contingency management, essentially utilizing incentives to reinforce abstinence. There is no FDA indicated medications for cocaine use disorder. There are some studies that are out there that suggest topiramate and baclofen can be effective in cocaine use disorder. There's this randomized clinical control trial that was done in 2013 that showed 300 milligrams of topiramate daily compared to placebo decreased overall use, resulted in clean urines and decreased cravings. There's another study done in 2003 by Shop et al. It showed that use of baclofen statistically reduced the use of cocaine with use of 20 milligrams of baclofen 3 times a day over a 16-week period compared to placebo. Methamphetamine is also another stimulant that's abused. Symptoms are similar to when somebody utilizes methamphetamines. The symptoms are similar to cocaine, but they are more intense, and the duration of activities is significantly longer than that of cocaine. So it could be 8 to 24 hours. It could be ingested, it could be injected intravenously, it could be smoked. And with chronic use, you could have things like dental caries, gingivitis, myalgias, rhabdomyolysis, hypokalemia, hypomagnesemia, excoriated skin. You could have psychiatric symptoms like depression and psychosis. Now, the psychosis with methamphetamine is much longer than that of cocaine. It could last a year or even years. And depression can last for several months. Again, treatment, incorporating behavioral interventions, self-help like 12-step, CBT. There is no FDA indicated medication for the management of methamphetamine, but there are studies out there that suggest the use of mirtazapine at a dose of 30 milligrams daily can be helpful in decreasing overall methamphetamine use and decreasing dirty urines associated with the use of methamphetamine, clearly because somebody's not abusing methamphetamine as much. This is an illustration of an individual that is injecting IV heroin. This is a community in Kensington, Philadelphia, in Pennsylvania that has a high rate of opioid use disorder. And as you all know, that opioid use disorder has become an epidemic in our country. Per the CDC in 2018, there's roughly 15,000 heroin-related overdose deaths. According to the Department of Health and Human Services, in 2019, there was a rise in the number of deaths attributed to the use of synthetic opioids, like fentanyl. Roughly 31,335 deaths in 2018. Opioids work by essentially binding to various transmembrane neurotransmitter receptors like mu, kappa, and delta, and affect cellular signaling. When they activate the mu receptor in the central nervous system, it causes respiratory depression, analgesia, can cause euphoria or miosis. When they stimulate these receptors in the peripheral nervous system, you get suppression of smooth muscle cells, leading to cough suppression. It could also decrease GI motility, leading to constipation. With chronic use, users develop a tolerance to the sedation and the respiratory depression, but they do not develop a tolerance to the constipation or the miosis. When users stop using the opioid, they have withdrawal symptoms. And these symptoms, there's multiple symptoms from nausea to vomiting to diarrhea, restlessness, myalgias, diaphoresis, abdominal cramps, dysphoria. And we often utilize a clinical opioid withdrawal scale when we're assessing the severity of somebody's withdrawal. And we are looking at these particular symptoms. The onset of action of an opioid is really dependent on the type of opioid that's used and the route that it's used. If somebody was to inject heroin intravenously, its duration of activity or how long it lasts in the system, it could be up to 4 to 5 hours. And that's partly due to metabolites like morphine. Somebody was to inject fentanyl, its onset of action is pretty instantaneous, and it can last half an hour to an hour, or it can last 1 to 2 hours. But keep in mind that fentanyl is significantly more potent than that of heroin. So that could also have you could also see varying symptoms due to that level of potency. One thing that I do think it's important that we're all aware of is that there are medications that are FDA approved for the management of opioid use disorder. And these medications help reduce mortality, reduce morbidity, and reduce drug-related crimes. So they're very beneficial for our patients. In regards to morbidity, they decrease complications that are associated with intravenous use, such as infections such as endocarditis, osteomyelitis, and bloodborne pathogens such as HIV and hepatitis C that could result from sharing needles. Methadone is a opioid receptor agonist, and it's a full agonist. It can help prevent withdrawal symptoms for up to 24 hours. It's really a long-acting drug. It's available in methadone clinics, so it's highly regulated, available in these particular clinics, as well as in the hospital setting. Oftentimes in the outpatient setting, there's counseling that's a component of, that is required as a component of receiving this treatment. Generally, when somebody is started on this medication, they're given 20 to 30 milligrams daily when somebody has they're in a moderate level of withdrawal. That's indicated by a CAL score greater than 12, in some cases greater than 10. A dose of 30 milligrams is generally sufficient to help with withdrawal symptoms, but patients require higher doses to help with the associated cravings. And the target dose is roughly between 80 to 100 milligrams. And it's at this dose that it helps eliminate cravings, and it's not sedating, and it's not causing euphoria.
Aedome, 10 minutes left.
Okay, thank you. Some common side effects: constipation, peripheral edema, decreased libido, erectile dysfunction. One side effect that we should be aware of is that this medication can prolong QTC and lead to the potential of heart rhythms that can be deadly in nature. And this occurs at a dose of 100 milligrams or more. So if somebody has cardiac risk factors, has a history of arrhythmia, history of QTC prolongation, you may not want to utilize this medication, or may consider obtaining an EKG, assessing what their baseline is, if no concerns, and starting the methadone, and then assessing their EKG several weeks later. If somebody has severe obstructive sleep apnea, severe COPD, then that's a population that you may not want to utilize this medication in. There are drug-to-drug interactions that can occur. And if somebody's on another respiratory depressant, like alcohol or benzodiazepine, that can increase the risk for respiratory depression. It can be lethal in overdose. If somebody, if you're taking this medication for a while, it's common that hyperalgesia can occur when somebody takes opioids for a long duration of time. We want to monitor, another point that I'd like to bring up here is the risk for neonatal opioid withdrawal symptom in pregnancy. So yeah, there is this associated risk, but there's also this benefit that, so if somebody's on methadone and they're being supervised clinically, they're getting a quality product compared to somebody going out in the street and utilizing heroin or fentanyl, and increasing their risk for bloodborne pathogens and various impurities and the side effects of the drugs themselves. So it's important to have this conversation with females that are pregnant. Buprenorphine is also another medication. This is a partial mu-opioid agonist. It has a high affinity to that mu-opioid receptor. In this high affinity, it's important to keep that in mind, because if somebody is taking an opioid, you start them on this particular medication, you increase the risk of withdrawal because it often displaces that opioid from that receptor. So it's important that they are on withdrawal prior to starting this medication. It can be prescribed in the clinics, but it requires an X waiver to be obtained. So if you're a prescriber, get your X waiver, because you could really be helping a lot of lives. And this has been shown to be an effective medication to help with treatment of opioid use disorder. There's various formulations available. There's a buccal film strip. There's a transmucosal tablet. There's a monthly injection. There's an implant that can be given every 6 months. One thing I want to mention is the difference between Suboxone and Subutex. Suboxone is a medication that's a combination of this partial agonist, buprenorphine, and this full antagonist, naloxone. So when somebody takes this orally, they are able to get the effects of buprenorphine. But if somebody was trying to inject the Suboxone, they will not be able to get high off this medication because naloxone will block that receptor. But Subutex contains buprenorphine alone. So if somebody was trying to abuse the medication and attempted to inject intravenously, then they have a chance of being able to obtain euphoria or get high off that medication. Dosing, generally you utilize 2 to 4 milligram dose, assess for withdrawal, assess for tolerance to the medication. If withdrawal has not been controlled, then you would give an additional 4 milligrams. Generally 8 milligrams is sufficient to manage withdrawal symptoms. Maintenance symptoms is between 12 to 16 milligrams daily. Again, it helps decrease relapse. It helps decrease all-cause mortality, even lower than that of methadone. It helps decrease the risk of death and overdose if somebody was to overdose on this medication, because it has a maximum ceiling dose of effect. So And at this particular dose, any higher dose would not increase risk for respiratory depression. However, if this medication is taken in concurrently with alcohol or a benzodiazepine, it's at that point you do increase the risk for respiratory depression. In pregnancy, it does have the associated risk of neonatal opioid withdrawal syndrome. But however, it has a shorter course of a hospital stay compared to that of methadone. So somebody uses buprenorphine, gives birth, a hospital stay is generally 10 days compared to 17 with methadone. It also decreases the duration of neonatal abstinence syndrome, 4 days compared to 9 days with that of methadone. Naltrexone is another medication that's FDA approved for opioid use disorder. But there is a high rate of lack of adherence with the oral formulation. So it's not really that as beneficial compared to methadone or buprenorphine. With the injectable formulation, the Vivitrol injections, it has been shown to decrease relapse, but these results waned after discontinuation of this particular medication. If you are going to use naltrexone, it's important that somebody is off of opioids in general for up to 7 days. If they're on, for example, from heroin, if they are on some longer acting medication like Suboxone, at least a minimum of 7 to 10 days. And if somebody's on something even longer acting like methadone, at least 14 days before starting this medication. And that concludes the presentation. Thank you for your time.
Well, thank you so much, Aedome. I mean, such a clear and thorough review of, you covered a lot of grounds, neurobiology, epidemiology, and management of 5 major substances. So really did a good job. There are a lot of good questions, so I will get to them in order of relevance to what you were saying last. So Kyle Walker mentioned the question, I've always been confused about the medical purpose of Suboxone, the 2-drug combo, the buprenorphine dash naloxone. Isn't buprenorphine much higher receptor affinity than naloxone? And if so, would including naloxone in the mix do anything to block the effects of buprenorphine when they're taken together? What would you say, Dr. Girma?
Kyle, that's I think that's a great question. So this question has more to do with the bioavailability of naloxone when taken by mouth versus when taken intravenously. So
taken sublingually, you mean?
Yeah, sorry, sublingually. So if taken sublingually, the bioavailability of that naloxone is so low that it really has no activity. But if taken intravenously, then there has bioavailability, and then that action of blocking that particular receptor occurs, and then it would precipitate a withdrawal, and also would not, you're not going to get the effects of buprenorphine as well.
Yes, and there's also another comment from James Anderson about the waiver, the X waiver for Suboxone. It's more a comment than a question, but I think it's worth mentioning. I did not know about this. It seems like recently they've changed the laws where if you are planning to treat less than 30 patients with Suboxone, you just need to submit a notification of intent. You don't need to complete the training, which is new information to me, actually. And there are some links that the audience can look into that were submitted by James Anderson. There's a question from Dr. Gonzalez. He's asking, can you comment whether there is a need to be completely abstinent from alcohol before starting naltrexone? And what would be the risk for liver damage if a person is drinking and taking naltrexone together? So kind of a two-pronged question about alcohol and naltrexone, Dr. Girma.
Yeah, so you don't necessarily have to be completely abstinent from alcohol use when taking naltrexone. So that's part one. And in regards to liver damage, the risk of the use of naltrexone, it is, if you're abusing alcohol, you do have a higher risk for liver damage. One thing that we could do to mitigate that is to obtain the liver function test to assess the baseline functioning of the liver itself. And if there's no concerns there, and it's at that point, you could go ahead and proceed and prescribe the medication, and periodically obtain LFTs or liver function tests to assess, how the liver is doing and functioning.
Yeah, and I want to add something about the first question. While there is no physiological reason why we can't start naltrexone while someone who has not completed the detox. The studies that looked at naltrexone effectiveness in alcohol use disorder, they established higher efficacy when naltrexone is started a week after detox is done. So it's more of a matter of interpreting the research and interpreting the scientific data. But clinically speaking, we in the hospital, we can start people on naltrexone while they are still in detox or they were still withdrawing. There are no physiological barriers to that. And sometimes, especially, it depends on your setting. Like in the consult service, we don't have the ability to wait for people to be detoxed for a week before starting them on the medication. So we started earlier. But it's been commonly known that it's best to wait that week. However, with that waiting, you're kind of weeding out the patients that actually remained abstinent a week after detox. Is that a self, kind of selective group? That's another question, but a great question from Dr. Gonzalez. I don't know if we have a time for, because there is a fourth question, but we are out of time. So I don't know, Tony, what do you think? We can go for that slide question from Dr. Khorshid?
Well, you can stay as long as you want.
Great. Okay.
And I just want to remind everybody that just pay attention whether grand rounds will occur next week in your email.
Yeah, great. So there's this last question. Thank you, Tony. From Dr. Khorshid, who says, how much of benzo use you think is iatrogenic versus street use? Do you have any thoughts on that? Like when you were looking at benzodiazepine use disorder literature, was there a distinction between the benzo use disorder that's coming from prescription, from doctors prescribing it versus people obtaining it on the street? I don't know if you came across that in your readings, Aedome.
Yeah, I mean, I think that's a great question. Honestly, I have not come across, that information, so I can't provide a clear-cut answer on that.
Yeah, me too. I mean, that's a really good question. I don't know if any of our addictionologist colleagues were on the meeting, if they can comment, whether on chat or if you can unmute, because we are kind of officially almost outside of the time of the grand route. Please chime in. But I don't. I'm not aware also of data that saying benzo, this percentage of benzo use is because of prescription versus that's just people buying it off the street, even though it's a really good question, because we do prescribe a lot of benzodiazepine. It's a good tool that we have in our training, but it's a double-edged sword, that comes with the risk. Okay. Well, since there are no other questions, I think this concludes the grand round. Thank you again, Dr. Girma. Thank you everyone for attending, and hope to see you soon. Bye.
Thank you.